Hello, my name is Sergio Rubinstein, and I do want to thank Dental XP for inviting me to give this presentation today. The topic that we have selected is the ultimate restoration. We do face ourselves every day in our practice with patients that are more knowledgeable than ever before, and their demands for top aesthetics is every day an issue in our practice. So what I'd like to talk about is what is the purpose of the prosthetic or restorative treatment? Ultimately, what we like to do is reproduce the appearance of a natural teeth. As we're going to reproduce the natural teeth, do we want to sometimes improve the existing aesthetics? It is quite often that nature has given us a tooth that does not have the right shape or proportion or the position where it's at, and we would like to improve on it. So therefore, with our restoration, we would like to create as natural effect as possible. In order to correct this, we would like to also stabilize an existing problem. So we would like to know that we're never going to compromise the patient's periodontal health overall. So the benefits are going to be, of course, aesthetics, because that was one of the demands that the patient had. The other one will be occlusion. It is in my opinion that in many instances, why a restoration will fail or succeed will be because of occlusion. So paying close attention to it will be quite essential. And again, periodontal health should never be compromised. When a tooth is lost, it will absolutely have an effect on the surrounding supporting gums and bone. And we need to be very conscientious about such an issue. Therefore, if these anatomical structures, bone and gums, will undergo permanent changes, can we conceive that such changes be only corrected with excellent prosthetics, either on natural dentition or implant supported? The answer is no, unless these changes are minor. We could have an excellent lab technician and make up for some of the deficiencies that the patient's problems may have. We must always have very close communication between the dentist, the surgeon, if in case there is a surgeon involved, the lab technician. We should not bring a lab technician into the equation at the end of the treatment. We'd like to do this at the beginning. And of course, we have to have in consideration what are the patient's demands, what are the patient's problems. So good communication, it is essential for us to achieve the desired objectives. We'd like to talk a little bit about color and how we select and understand color today. The basic thing that we have always looked for is the hue. That is, when we're talking about color tone, that will be red, yellow, green, and blue, and this is how we communicate color or have had done so in the past. Furthermore, we would like to have a very good understanding of the chroma. For the chroma, we know that the intensity of saturation of color, when we communicate this with the lab, is very important. We may select the correct hue, and we need to describe as well the intensity of such hue. One of the things that we have done in the past is always look at the value at the end, and it is more important for us to understand and describe the value from the very beginning. When we select the shade, we always do that when the teeth are moist, and the value represents the brightness of a color independent of its hue. When we see a patient, a person at a distance, and we noticeably can detect that the crown is artificial, that is because the value has been incorrectly selected. So what we'd like to do is select first the value. Once we have the correct value, it will be easier to select the correct shape. When we select the value, we like to do that at a distance, and we will not be that close to the patient, so we will step away. When we select value, we also would like to take pictures in black and white. This is going to confirm, because there's no color involved, that we have the correct brightness of the hue that we may have selected. As far as the shade guides that we've used, we have the 3D shade guide from Vident, which is based on value. But we can also use any other shade guide and take a black and white picture. Or this could be corrected on the computer by removing any of the colors. Among the most common shade guides that we use today that can give us a very good reproduction on the colors and different tints that the lab technician will utilize is the Noble Rondo guide. And we like it because the small round balls that we have on this guide allows us to get very close to any particular area of the tooth. And this way we can communicate with the lab technician in a closer way the shade that we have selected. So in order to do that, what we'd like to see is first, again, at a distance, select the value. Once we've seen the value, we will then get closer. As we get closer, this is going to confirm, do we have the correct value or not? If the value is the correct one, we take a note of it, and we can take an additional picture on a close-up that can be emailed to the lab technician, and in this format, magnified for them to see all the intrinsic colors that may be needed in order to reproduce a natural crown. When we're looking at the gingival tones, we have several options, and if we do not find the correct one, at least the lab technician will have a very good reference. Is this the correct hue? Do we need to modify the chroma, as well as utilizing selective tints? So instead of looking at an entire tooth for shade selection, this allows us to see any specific area with better color to be reproduced by the lab technician. So here we have a 62-year-old male who had a fractured upper canine shortly after a root canal treatment. The tooth had to be extracted and a bone graft was done. After 4 months of healing, the implant was placed and we allow it to heal for an additional 4 months. There are instances where we can utilize this implant in a shorter term. But I do strongly feel that allowing for a little bit longer healing time is quite important, especially when we're planning on giving a patient a restoration implant support which could actually last us a lifetime. After the 4 months of healing, we are ready to take an impression and fabricate either a provisional or going to the final crown. As we can see here, there was already a little bit of recession on the distal of the lateral. And we know that once the papilla is lost, it will not be regenerated. We may be able to, with the soft tissue support with the crown, create a smaller papilla, but it will never be at the same height because the bone loss that had already taken place. So here we have an Astra implant, and the shade that we're using here is a 1C on the Ivoclar shade guide. And we'd like to confirm this with not only one, but several shade guides, and we'll also like to evaluate if this is the correct value. Therefore, we're going to take pictures with different shade guides and utilize them on a black and white and color as well. This can be sent to the lab technician and it will corroborate, first of all, if this is the correct value. We know that patients can have teeth with different colors, but if the value is incorrect, the crown will not have a natural effect. Once we have selected the correct shade, the correct value, we get the crown back. In this particular case, the patient had a crown that was screw retained for retrievability, and we like to have that with a lingual transversal screw. This was created with a custom abutment, allowing us to recreate the lingual contours as close as possible to what the original canine was. From a buccal point of view, we're trying to have the natural not only color and brightness, but we also like to have texture. As we duplicate this, the patient will have a restoration that will have the light deflected in different directions and give us a natural looking restoration. The next patient is a 34-year-old female, which had also root canal treatment completed as a child, and she's unhappy with the aesthetics of the upper left central. She's had bonding for several years, but at this point we'd like to have the best possible aesthetics with no compromise. On the previous case, we show a crown that was porcelain fused to metal. And here, the patient having bonding will like to have something that will not change color as frequently. So we like to do, anytime we have an aesthetic case, take pictures from different angulations. So we will take a frontal view as well as lateral views. This allows us to evaluate not only the patient's concern as far as the aesthetic on the tooth, but as well as the smile and tissue profile. We can see from the lateral view on the left slide that the tooth next to it had slight rotation on the upper central. Are we going to duplicate this contour, or are we going to offer the patient orthodontic treatment? It will be quite advisable to do this during the treatment plan stages. So once we evaluate the aesthetics without the lips have gotten out of the way, we can see that there's also gingival recession. We have recommended for the patient to go through connective tissue grafting, and at this point it's not something that the patient is interested on. Therefore, we should focus our efforts into what the patient wants. So we're going to concentrate on restoring the central to the color and shape that the patient has desired to have for so long. So we take an isolated picture with a clearer view of the adjacent central, and we can evaluate that there's a little bit of irregularity as far as discrepancy on gingival tissue. One is fairly rounded, where the adjacent central is flatter, and there's a little bit of recession on the lateral. The patient does not want to address that at this point. So we need to focus our efforts into the color and contour. As we start to prepare the tooth, it is important to give the lab technician adequate room for him to be able to reproduce what the natural tooth, the natural crown is going to look like. Therefore, we need to have enough clearance on the incisal, and we need to look at this from different angulations. It is quite frequent that not enough reduction on the lingual aspect is given to the lab technician, and we can end up with a crown that's fairly bulky or actually create some interferences with the occlusion when the patient goes into protrusive movement. We also want to look at this from the side. We know that the anterior teeth on the incisal third taper in, and it is quite frequent that we don't give enough room to the lab technician. Therefore, creating a natural profile will allow the lab technician to have all the colors that are required with a normal shape. So we can evaluate soft tissue profile and corroborate that the shade and value that has been selected is the correct one. What we'd like to do is create a provisional that the patient can live with for quite a while. On an aesthetic case, sometimes we need to do the crown a few times. The more information we give to the lab technician, the less mistakes, the less remakes we will have. Therefore, it is important to create a provisional that's going to have natural contours. So here we're trying to reproduce similar contours to the adjacent central, texture, and brightness. We take an alginate and we duplicate this alginate and give it to the lab technician so he can use this as a reference. In this particular situation, the patient did not want to have any metal substructure, so we decided to go with a Procera coping, which can be either alumina or zirconia. In this particular case, we use zirconia because of the darkness, while the alumina coping could have worked as well. The die needs to be scanned in order to copy in the computer the shape of the preparation. This way the information will be in the computer, and what's being done is little dots are created on the margins. These dots are going to be connected, and therefore it's going to give us the information on the length of the coping. It is important to create a deep undercut below the margin to determine where the margin of that coping will be finished. So we can make these corrections on the computer, and this is going to show on a large scale if the preparation was smooth or not. Once we click the OK and we have approved the margins, the computer is going to generate the design of that coping. It is important to have the case mounted on the articulator. The purpose of it is that we know that porcelain needs to be supported. As we were going to do a porcelain fused to metal crown, we need to have enough metal support for cusp and interproximal marginal ridges. The same thing is with these copings. So a double scan needs to be created in order to have adequate support and the porcelain be uniform. And here we have the final restoration, where the patient had to live with for about 2 weeks, temporarily cemented. Once the patient is giving us the final approval, we can proceed and permanently cement it. In the next case, we have a patient that's 20 years old, and she was in Chicago for just a summer. She had had an accident 12 months ago, and she had a crown completed 6 months prior to coming to our office. The patient was unhappy with the crown. It is a lot easier to treat a patient that understands what is the specific problem, rather than us trying to find out what is it that the patient is not happy with. The more the patient tells us, the easier it's going to be to please the patient. She was also dissatisfied with the gums around the crown. The question that we had was, the dissatisfaction was because the accident had created this problem around the gums, or was it because of the crown? We explained to the patient, in order to correct such problem, we're going to need to do at least short-term orthodontics. The patient allows us to do short-term orthodontics that will be inexpensive. So when we take a close look at the crown, we can see that the value was improperly selected, even though the hue was not that bad. But the major problem here was the value. We can also see the irritation at the gum line, and the crown was slightly bulky, had a slight overhang, but we also have a gingival recession. With this gingival recession, we did not know if this was because of the trauma or because of the crown. And the patient understood that this discrepancy will have to be handled and may be corrected with orthodontics. So the crown was removed, and we were able to determine that the preparation was quite irregular. It is very important to have a nice, smooth margin. If we have a nice, clean preparation with a smooth margin, it will be easier to take an accurate impression for the lab technician to reproduce such contours. While this can be done with a regular turbine handpiece, my personal choice is to use electric handpiece. I believe all the ones that are in the market are very good. The one that I utilize is the NSK. It's now Brasseler, but it allows us to have better torque and better control on the definition of those margins. Also, we had created a provisional, as you can see on the right, the picture, where the provisional is trying to duplicate as close as possible the shape of the adjacent tooth. Yes, we can recognize that this provisional is longer, but this is the way the tooth had been prepared. So in order to improve the gingival discrepancy, we want to super up the central. To do that, we decided to create orthodontics in a simple manner. And this was done by actually placing composite buttons on the adjacent teeth. So with composite on the adjacent buttons and on the provisional, the elastic is going to come down. As the elastic is trying to go into its original position, the central incisor needs to be shortened to allow for the tooth to be super erupted. We also do not want to have undesirable torquing movement from the abutment, the adjacent teeth that are supporting the elastics. So we give the patient an Essex retainer that has to wear at night. This way will not have any undesirable rotations. And a small window to allow for the central to come down. Every time the central is coming down and it's touching the adjacent teeth, we need to adjust the incisal third. This is the original crown, and the picture next to it we have the crown completed. We were able to duplicate contours, color, value, the incisal effects, and just as important, texture. Many times if we do not duplicate the texture, the light will bounce back at us. Having texture will allow us to deflect the view from any given light to allow us to see a crown that's more natural. When we see the patient smiling, we like to evaluate on a retracted view without the lips, and of course see how the patient's smile is ultimately. We're able to reproduce natural contours and line angles to the satisfaction of the patient. Thank you.